喂喂，喂，喂，喂。刚刚讲到跟他说外面要上，我觉得很危险。有给他们了吗？有啊，上礼拜就给。好，我这是上可能最后再请那个博弈给他。OK，好。 Hello. Yeah, good to see you. Thank you. Oh, what is your, I'm a. Oh, great. I was just telling the guys that I was in India recently. And they. Really? Experience makers. No, this is only for we got only for animal. Yeah, we got about we went to the Southeast Asia. I want to get nutrition. How to buy it's not the situation. Yeah. So sometimes, but not as a device. So one of the beginners ago, I think important maybe more than it's made the integration with that. Run that ground loss on a custom. No, what is this? I say the medical device. And I say to the customer, one day you might need it. Have you done this? Okay, these are our procedure in previously in East Asia. Of course, since I'm going on your base, since you went to Australia. Yes, previous in the States, but how about a month? Wait, you know, in the farm, right? Yeah. All of my friends no. Well, this is a very long yeah, so what's my my boss. Ah, so yeah. 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 It's they get a bonus on the publication does. In Taiwan is it a policy to get a bonus? Yes, for publication. Oh, good. Yeah, because Podium's got lots of publication. Right, so therefore his salary is bigger than me. Yeah, publication. That's interesting. Oh, so I see you have a lot of fire. Yeah, I think that's what we started to do. Australia. I see you. Very kind of. And so we followed there. Each one. Australia, so oh yeah, well, the calculation much better. Right. Design new device. Will be much soon. Yeah, always the first one, second one. Yeah, location figure. It's been very difficult.
any wireless pacemakers now.
Really?
Yes. Pacemakers that not have a lead.
Yes, it does pacemaker.
Okay. That's like in it's very useful.
We are also have a first one, so about maybe 5 years ago. Yeah, it's very simple when I take the accounts of those right now, this point is single reason that's but in Australia, the border things are much closer. Yeah, that makes sense.
What do you think is what
You basically make also the yeah, you get to become all the time. So I don't know, it's going to be strict. Yeah, and we once you have an infection, I know no, yeah, so we keep this very short. And the same thing it cannot different because it's outside, it's right, it's yeah.
So, sorry. And you could make a meeting for 6 years. And when they bring the leads are
yes, because if you think lifting, there's wire was made a bigger team part. Otherwise, it's written how you research should be device to the need. I mean, if I was yes, otherwise, even yeah. Oh, then I after I pull out this switch. So this may have I want. These are the yeah. It's fortunately not strong in the 21st century. So we cannot have a hard people.
so that's one that I
Thanks, me nervous, but I have to renew the driver's license
once a year, but you just got to renew.
8 years. It is nothing to that. I need to work on so license well,
And his one.
Is it on? Yeah.去哥们儿，首先是当中你还得都是一个圈，都是yes. This is yeah, average is one when you see the more every day will comes. Bits. One previously, the next year will be, next year will be more solid. Because we are setting the economic rate, previously 400 rate, after COVID become almost 1,000. So they said, so you have a burden for healthcare. Even after this is why we have now maybe the effect of a lot of people everything is yeah, maybe just try small something. Yeah, like we said, it's brain recruiting. Many questions interested in internal medicine or here we have 60 years. Medical training after 2 years, issue-wide 4 graduate training. The first year is located in second year to the problems. And simple. Each year, maybe 50% and 40% GY training will be it is good. Yes, they are. So imagine the teachers they know that there's COVID and last year they got shut down. I talked to the Korea University last year, so it's one. This year what they say for 3 years ago, after COVID, the staff take care of the duty. Even after the COVID right now, they have to take care of it. Even the doctors have to be on the duty for the agent and having any of everyone's skin like a little bit cosmetic. Yeah, you don't like it. Having skin is very good, very nice, but now some people is very bad. And we speak like that, that's good afternoon, dear colleague, my guest. So today we are honored to have Professor David Patterson to be with us for the Grand of internal medicine. The title of the talk is the battle against resistant brain active now and the future. I know the Professor Patterson is a leading expert of the antibiotics resistance. Currently is a professor at National University of Singapore and director of the Advanced ID Clinical Trial Network across Asia. I think this is a very big trial and very important trial of the whole Asia. Incredible, he has published more than 600 peer-reviewed articles and also contribute greatly to improve the treatment of antibody-resistant infection. So I think his research interest is molecular and clinical epidemiological infection of antibodies-resistant organisms with the intention to translate the knowledge into the prevention and treatment of antibodies infection. So today we have privilege and to have Professor Patterson to be with us and to have the insightful current landscape and future direction of the to treating the resistant gram-negative bacteria. Let me join us to welcome Professor Patterson.
Thank you very much for the lovely introduction, and it's great to be here in Taichung. I now live in Singapore, but I do not speak Mandarin, I'm sorry, and I do not speak Hokkien, because many of my colleagues speak Hokkien, which I think if you are a Taiwanese speaker, you can understand Hokkien. But I come from Australia, and it's interesting that Australia and Taiwan have many similarities. So I put into ChatGPT, what are the similarities between Australia and Taiwan? And of course, we are both liberal democracies. We have almost the same population. In Australia, we have Aboriginal people, just like in Taiwan. We have quite a progressive society, and I won't talk about China. And there are many other similarities and a lot of trade between Taiwan and Australia. So even though I don't speak Mandarin, I feel very much at home when I come to visit Taiwan. So this is my city in Australia called Brisbane. And interestingly, it's very similar in latitude to, for example, Taipei. I guess Taichung is a little bit more close to the equator than Taipei, maybe by 200 kilometers. But basically, our climates and our lifestyles are probably quite similar. So I did my internal medicine residency in Australia, and I would like to start by talking to you about a case I saw when I was an infectious diseases resident. So I was called because this man had chest X-ray like this, and he was the owner of horses, and 12 of his horses died. And so the ICU director contacted infectious diseases. What could be the link between this chest X-ray and the death of the horses? And then around the same time, a man came in with aseptic meningitis. So he was confused. He had lumbar puncture that had 200 lymphocytes. And this was his MRI, which was very, very bad. And it turned out that both of these patients had the same infection. And it was a novel virus that was called Hendra virus. And interestingly, it was related to what we call flying foxes, which I think you call fruit bats. So you have fruit bats in Taiwan? And what happened was that the bats were the natural reservoir of this virus. And if they urinated or there was amniotic fluid near where the horses were eating grass. The horses developed the infection. And then my first patient owned the horse, the one with encephalitis. His wife was a veterinarian, and the man would do the dissection for his wife of the dead horse. And that's how they acquired this infection. Interestingly, there is another virus called Nipah virus, which is almost identical to Hendra virus. And this caused a large outbreak in Malaysia and Singapore among pig farmers. And now in some parts of the world, it still exists. So wherever there are fruit bats, it's now been found in the Philippines, and I didn't realize how close Taiwan is to the Philippines. So if you want a New England Journal article, just think, if you get someone with a strange encephalitis or a strange pneumonia, it could be Taiwan's first case of this virus, particularly if there's some link to fruit bats. So that's just a tip for you. But I need to speak to you about gram-negative infections. And the reason I moved to Singapore was to be part of Asia, because there are more people. In fact, 60% of the world's population lives in Asia, and undoubtedly more than 60% of the world's infectious diseases are in Asia. And so if I want to study infectious diseases, it's best to live here. So how big is the problem? Well, there was a nice paper in the Lancet that looked at the burden of disease. And when you consider all of the gram-negative bacilli, the disability adjusted life years lost from the gram-negatives is actually bigger than TB or HIV or malaria or dengue. And yet I think all of our politicians, if they're Blue Party or they're Green Party, they will have heard of TB or HIV, but I don't think they have heard of H or Acinetobacter. And yet these are a bigger problem. When I visit our colleagues in India or in Indonesia, if you have carbapenem-resistant KP, you have a 50% mortality in 28 days. Now, if I had a cardiac arrest here, right now, I think my 28-day survival would be better than 50%. I hope.
Yeah.
If you're here. If I was diagnosed with an acute leukemia, I think my 28-day survival is better than 50%. So these resistant gram-negatives have a very high mortality, and yet there is not the recognition about them that there should be. So since we are almost at the end of the year, what I would like to do is briefly tell you about the top 10 papers in this field in the last year. And one thing that I am now starting to do is we are sending to all of our network a newsletter every 2 weeks, just summarizing the most recent papers. And we do it, I think this is so bad. This is simplified. It's simplified. But people in Taiwan can read simplified, even though they use traditional. Can people in China read traditional or difficult? Difficult. So, if you want our newsletter in either English or Chinese, feel free to subscribe, and you can get the up-to-date papers on infectious diseases that we'll send you every 2 weeks. I wish it was about electrophysiology, but sorry, we only do ID articles. So the first paper I wanted to talk about was a trial that we did in Australia and New Zealand. And this trial looked at a very simple nursing intervention. And that was, we randomized patients to either what the product information says about giving meropenem or piperacillin tazobactam, which is to give it over 30 minutes, or to get the nurses to give it over 3 hours or longer. So this is an intervention that costs zero money. And yet, when we did a meta-analysis of our results with other trials, the mortality reduction is statistically significant in favor of a prolonged infusion. And so basically, this is a zero-cost intervention that can be applied in our ICUs in people with sepsis by giving a prolonged infusion of antibiotics like meropenem or piperacillin tazobactam. This will save lives. So that's the first article I would like to talk about. Now, I do need to acknowledge that our lunch today and my travel here is sponsored by the company called Shionogi. And it's interesting that their new antibiotic, actually, they do talk about this long infusion. They recommend that it is given over 3 hours. So the next article and the next concept I want to talk about is a thing called augmented renal clearance. And basically, this is relevant to any drug, not just antibiotics. If your drug has a short half-life and the drug is renally excreted, we know that there are some patients who actually have a high creatinine clearance. So if you have burns or recent surgery or pancreatitis or a severe infection, you get an increased cardiac output, you are vasodilated, and as a result, you get increased renal blood flow and an increased GFR. So the consequence of this is, for example, if you have a young guy who falls off his motor scooter, has a head injury, ends up in the ICU, his creatinine clearance might actually be 180 instead of 100. And so any drug that has a short half-life and is renally excreted, we may end up with underdosing. I guess, if we had a young person with an out-of-hospital cardiac arrest from an arrhythmia, or there's many scenarios where this concept of augmented renal clearance comes into being. And the consequence for treating infections is if you recognize this phenotype, the patient's got normal renal function according to urea and creatinine, but they're young, or they might have had burns, they might have acute pancreatitis. These people can all have a creatinine clearance of well over 120. And these patients need their antibiotic dose either increased or given more frequently. So, for example, sometimes we give meropenem 2 grams every 6 hours in these young people. And in fact, in the cefiderocol, the Shionogi antibiotic, they have it in their dosing information that if the creatinine clearance is equal to or more than 120, they give the dose over 6 hours instead of what is normally over 8 hours. So it is something to remember. Now, of course, we also have many elderly patients who've got renal impairment, and they will need dose reduction or doses spaced out. But it is important to think about this possibility of augmented renal clearance. So can I ask, who has seen a patient with a liver abscess due to KP, Klebsiella? All the ID guys, even cardiologists have seen it. So this is actually a disease process that people in Taiwan should be proud of, because, well, sort of, the first international descriptions of hypervirulent Klebsiella were actually from here in Taiwan. Now, what the WHO is talking about is that there is a confluence. There is both hypervirulence in KP and also the organism becoming more resistant to antibiotics. And there are a number of papers which suggest that this is associated with increased mortality. So one interesting paper that I saw in the last year looked at whether you should receive a carbapenem or a non-carbapenem if you've got hypervirulent Klebsiella, but the organism is susceptible to ceftriaxone or piperacillin tazobactam, so it's only resistant to ampicillin. Do we have to use meropenem in those patients? And the conclusion was that there is no advantage of using a carbapenem if you have a hypervirulent KP when the susceptibility says it's only resistant to ampicillin. So if the antibiotic stewardship team come to you and say you don't need meropenem, and you ask them, oh, where's the data for that? Ammunition to throw back at you, saying that in fact you don't need to use a carbapenem for every hypervirulent Klebsiella. Just very briefly, should we use combination therapy for hypervirulent Klebsiella? Unfortunately, there's not any randomized trials on this. It's interesting that there are some new Klebsiella-specific antibiotics being developed. And it might be in the next 2 or 3 years, there are clinical trials where people are giving some additional anti-Klebsiella products. This one is not a phage. You might have heard of phages, these viruses that kill bacteria. But the way a phage kills bacteria is there's a thing called a lysin, which lyses the bacterial cell. This company has engineered these lysins so that they are specific to Klebsiella. So this is something that could be a thing of the future that you might see at this hospital. Now, Pseudomonas aeruginosa, that is carbapenem resistant, is a problem, particularly in ICUs. And a number of us got together to try to review the evidence for what is the best therapy for this infection. And unfortunately, you're going to be a bit disappointed. In the last year, we have not been able to find any trials that have been able to differentiate between the major anti-pseudomonal antibiotics. So at the moment, it might depend on things like cost or local susceptibility, but we are not able to differentiate those three major anti-pseudomonals. Hopefully in the coming years, I'll be able to, maybe Paul, I could come back every December and give you an update and tell you what there might be. All right. Now let's talk about CRAB, Acinetobacter, that's carbapenem resistant. One of the main drugs potentially for this is one called cefiderocol. And this year we had published in the Lancet Infectious Diseases. And let's have a look at the authors. Professor Liu. And is Chen Hao here? So it's fantastic that in a journal with an impact factor, I think of more than 50, we have your colleagues on their authorship list. And in fact, they were amongst the biggest recruiters in the world in this trial. So what we found, and I'm sorry, some of this got cut off. This is the patients who received cefiderocol for Acinetobacter. 11% died. These received standard of care antibiotics, only 20% died. And when we looked specifically at carbapenem-resistant organisms, there was only a 9% versus a 21% mortality. So I think it's important for us to recognize that this is another option for carbapenem-resistant Acinetobacter infections. Now, also in the last year, there has been some publications on high-dose minocycline for carbapenem-resistant Acinetobacter. And I think these guys are from Taipei. Yeah. So it's interesting that out of the top 10 papers here, there's a number that have got authors from Taiwan. So this group looked at the use of high-dose minocycline. I'm just going to go through this for you. There was a lower mortality compared to standard of care, even when they did a multivariate analysis. And what they suggested is that our laboratories need to change the breakpoints to really best predict who's going to get the best outcome with Acinetobacter and high-dose minocycline. So I think those two papers do give us some important information about how we can progress past polymyxins for treatment of CRAB. But there's a lot going on with this organism. In the next year, we'll start a trial on intravenous rifabutin. So many of you will have used oral rifabutin, maybe as prophylaxis or sometimes treatment of NTM, particularly Mycobacterium avium. But there is now an intravenous formulation of rifabutin, which is highly active against carbapenem-resistant Acinetobacter. And it is also synergistic when it is combined with polymyxin B or also cefiderocol. So next year at this hospital, we'll be doing, in collaboration with Professor Liu, a clinical trial where we test rifabutin and polymyxin B plus or minus cefiderocol versus standard of care antibiotics for CRAB. And there's been a very small phase 2A study where there was a suggestion of improved survival when these combinations were used, and that's the rationale. There are some other new antibiotics being developed for Acinetobacter. I won't go through these in any detail. So I asked who has seen hypervirulent Klebsiella, who has seen an E. coli infection? No one? Yes. I think all of you in internal medicine would have looked after people with E. coli. And normally when we talk about resistance in E. coli, we talk about beta-lactamases. So, can we use a first-generation cephalosporin, or is there a ESBL, so we can't use those antibiotics? But I just want to tell you a little bit about bacteria and how bacteria become resistant to antibiotics. So gram-negative bacteria have got an outer membrane, like an outer wall, and also an inner membrane. And between the two is this space called the periplasmic space. And in that space is where there are where there are beta-lactamases. And the beta-lactamases can destroy our antibiotics. So, for example, if you had NDM, this is a beta-lactamase that can destroy carbapenems. But if our antibiotic can get across this space, what happens is that they bind to penicillin binding proteins, PBPs. But what we have discovered, particularly in the last year, is that we know that different beta-lactams preferentially bind to different penicillin binding proteins. But sometimes in E. coli, these PBPs can mutate. And as a result, we do not have the same binding to the PBPs. So this is a paper from the last year. And what happened was, if there were mutations in this penicillin binding protein, a number of antibiotics had an increase in MIC. And so the implication for this is that there is now a new mechanism of resistance, even in E. coli, to even some of our newest antibiotics. And that's going to be a shame. I think this one, Astrianam avibactam, is hopefully coming to Taiwan soon. But unfortunately, E. coli is already a step ahead of it. This has been most frequently found in India, in China, but when I was in Taipei on Friday, my colleagues at NTUH told me they've already found it in Taiwan. It'd be a very interesting thing to see whether it's here in Taichung as well, from a genomics point of view. So these are emerging. They're often associated with the worst type of carbapenemases. In the future, there are going to be some options that will get around this PBP problem, but none of these antibiotics are available yet. There's an Indian antibiotic called Zidibactam. Meiji, which is a Japanese company, has one called Nacubactam, and a French company has got one that is not actually a beta-lactam, so it's not destroyed by the crocodiles, and yet it can bind to multiple PBPs, so hopefully that will be sufficient. All right, I've got one final paper I want to discuss with you. And I'm going to have a quiz here for you. If I have E. coli in my blood from a urinary tract infection, how long should we give intravenous, or in fact oral antibiotics as well? How long should the antibiotic course be? Okay, so who thinks we should give it for more than 14 days, for more than 2 weeks? Put your hand up. Who thinks we should give the antibiotics for 2 weeks, for 14 days? Okay, number of people. Who thinks we should go for 10 days? Okay. Who thinks we should go for 7 days? So, who thinks we can go for 5 days? Maybe. So this was great because this is such a relevant RCT. They randomized patients, more than 1,000 patients, to 7 days of antibiotics or 14 days of antibiotics for uncomplicated bacteremia, mainly with gram negatives. So the results were that 7 days was just as good as 14 days. And so our standard of care should now be that if we have a non-complicated bacteremia, we do not need to go more than 7 days. Now, obviously, there might be some individual circumstances that mean we have to go longer, but routinely, we do not have to go for more than 7 days. All right. Let's try and summarize this so you can get some lunch. So first of all, if you have a patient with sepsis in the ICU, for example, an ESBL producer, there is a survival advantage if you give the meropenem as a prolonged infusion, at least 3 hours. Some people give it as an 8-hour infusion and then do that 3 times a day. Secondly, if you've got hypervirulent cleb that is susceptible to other choices, there is no advantage of using meropenem. Thirdly, with CRPA, we still don't know what is the best antibiotic to use. For carbapenem-resistant Acinetobacter, there's new data about both sapiniracol and intravenous minocycline. And because we generally now like to use combination therapy, perhaps that could be a suitable combination. And finally, 7 days of antibiotics is just as good as 14 days for most gram-negative bacteremias. Now, I'm not talking about Staph aureus bacteremia. I'm not talking about Enterococcus associated with endocarditis. I'm talking about, your patient with E. coli bacteremia from a urinary tract source, or that got cholangitis and had a stent change. That sort of patient, 7 days is enough. There are still a number of questions in antibiotic resistance where we don't have answers to. What is the best treatment when there's an MBL producer, particularly if there's those PBP3 changes? How about SM, Stenotrophomonas multifilia? What's the best antibiotic or combinations? Things like Elizabeth Kingia, which we see here, or Chrysobacterium. We still don't really know what are the best treatment choices. But hopefully, we can work together and do randomized trials so that we can come up with these answers. So, Sheshe, I look forward to answering any questions. Thank you.
Thank you, David. David is a truly gentleman for both infectious disease and any other thing in life. And everything I have done with David is really a amazing journey. And I was use some of David to express always amazing journey because that 就是我认识 David 的时候，大概是5年前，那个时候其实 David 那时候还在澳洲，就是无尾熊然后照片，然后后来到新加坡过去。其实我们那时候在台湾，我觉得在台湾做鼻饲或者是感染科医师，最大的问题是跟乌克兰药，我常常都没有药可以用啊，都会切在全球的供应链在，就有个药在这个病上看了5年了，学妹问我说有没有用过，可能不会用。所以那时候加上跟 Church House，因为那是我们唯一合法的机会去用到什么的 local 的机会了。我们试过有偏用，我们试过所有的办法，什么非常态情况啊，什么什么，差点真的不行，就只能走到英国去买啊，都没有办法。那唯一的机会，那后来跟 David 才到这个 Church 主要也是因为那是我们唯一有机会能够让病人免费用到 Biofan 跟后面药的一个方法。那当然我们没有办法让每个病人可以用到，但是至少我们不会受伤，什么东西都没有。然后很快的这段时间就过去，但 publication 那是后来的事情了。知道所以不晓得这个船会不会成功，我也不晓得。我知道手上有些东西可以用。那我想最近美国的其实大家都知道，我觉得就感染科来讲，就是无论如何都要跟周边好的国家维持良好的关系，不管在药物合作或一起未来一起把握上面。所以真的鼓励说，我们科里面的杨幂跟夏都能够尽量出国去，其实说是交朋友嘛，就是交朋友。Okay, and thank you, David, for your. I just tell everybody you are a really wonderful guy for giving us everything. Okay, and then go and all your daughter can go to Singapore to have a fun time in the chili crab. Okay, so is anyone have a question for David? I promise he will back in sometime in if you have some really nice question, you better ask now. Yes.
Professor, thank you for the excellent the talk. And I have one question is that because there is lots of novel agents, antibiotics for the CRPA. So if we do not have the susceptibility test for the MICs of these novel agents, which novel agents will be preferred in the first place?
No, that's a really good question. And so, for example, if you had a patient with Pseudomonas and there is a risk that they could have a carbapenem-resistant organism, you could choose between ceftazidime avibactam, ceftolozane tazobactam, and the choice might depend, for example, on your hospital antibiogram. So if you were able to put together the susceptibilities of your CRPA and see which of these antibiotics comes out on top, that might be the one that you might start first before you've got the susceptibility. Another thing would be if they've previously been colonized with Pseudomonas and there were susceptibilities done on the strain, that could help guide you. I guess the first question is it a carbapenem-resistant organism or is it carbapenem susceptible? And I think most of the time we are going to think it's more likely to be carbapenem susceptible. But if someone's in septic shock, if they've had a history of colonization with carbapenem-resistant organisms, they've had a long length of hospital stay, that's going to increase the probability that they've got a carbapenem-resistant organism. So it is tricky, isn't it? Without a rapid diagnostic, and even with the biofire, that can't tell us if it's a forum loss. You know, if there's no acquired carbapenemase, we still don't know whether it's going to be carbapenem resistant. So we certainly need to advance the science in rapid diagnostics to help us answer this sort of question.
Thank you, Professor. And I would like to ask, what is your view about treating non-DTR CR pseudo? Is it suitable to use some traditional antibiotics if it is susceptible?
Oh, yes. So if you, so this is Pseudomonas that is not carbapenem resistant. It's not resistant to multiple antibiotics. Could we use piperacillin tazobactam or cefepime? This is your question?
Yeah.
Yes, I think we could. We do always have to be aware of the appropriate dose and frequency because there's a risk of underdosing with Pseudomonas. But I feel we can use traditional antibiotics. Now, would I use an aminoglycoside by itself? Probably not. But I think if you've got susceptibility to the anti-pseudomonal beta-lactams, so I heard, you please help me, Paul, someone told me that in Taiwan, sometimes even a moxiclav can be active against Pseudomonas. Is that true? I've never.
I don't really think so.
Good. Okay, that's good. Let's forget that.
Yeah.
Because that's never been my experience, but someone told me it could sometimes happen. Just forget. So I guess one thing, just some advice to people doing their training in internal medicine or different specialties. If you are going to advance in your, not me, is it? Oh, time to wake up. You know, if you're going to advance in your career, how do you distinguish yourself from other colleagues? And of course, no one wants there to be promotion of someone who is incompetent clinically or is not a good guy or girl. But the differentiator is often your CV and your publications. And so I would strongly encourage you to be involved in research so that you can build your publication list. And that, I hope in Taiwan, that contributes towards your promotion. If you have a better CV, then maybe sometimes you even get rewards for good publications. So if you do have the opportunity to participate in clinical research, please do, because I think it benefits everybody, but it also benefits yourself.
And because you are here, I would like to have another one question. For some brilliant young guy who brave enough to choose ID as a career, what's the best thing he or she can do in the next 5 years? Consider we are facing many challenges globally, antibiotic resistance, some unknown disease, supply chain.
Yeah.
What's your best advice for these young guys?
So my mentor in the United States was a Taiwanese American, a man called Victor Yu, Y-U. And he told me, study what you see. And what he meant by that is, if you're in Taichung, don't build a research career on visceral leishmaniasis or trypanosomiasis. Do your research on clinical problem that you see a lot of. And so that's really going to depend from place to place. And I think here you probably do see a lot of patients with resistant gram negatives, and that would be a good thing to study. Probably you have patients with NTM. That would be interesting to study as well. You know, I don't know, but maybe things like device-related infections. what do you see clinically? And it's the same if you're doing nephrology or cardiology and you want to start your research career. Do it in what you see clinically. And if there is a clinical question which you feel has not been answered, that is even better to try to explore that. And that would be my advice.
Thank you.
I believe so, and I mean, as a physician, I believe every clinical research, actually every research we done, should direct to give our patient better care or even better chance is good enough.
Yeah.
So thank you very much. Can I have David is a really honored privilege to be here. Thank you very much. 我们鼓掌好不好？谢谢。Our hospital have a special gift for you. Do you know our hospital have a wine?
Really?
It's over here, your hospital wine.
Wow.
Okay.
Okay.
谢谢。
Okay. One more time.
And it is should be.
谢谢。But no, your boss probably had to go and do a procedure. Oh. Yeah, yeah.
And